Dr. Devi Vijay of the Indian Institute of Management, Calcutta, has been researching community palliative care in Kerala, India, for over a decade. Here she talks about why the Kerala approach is important and how it relates to the local context.
I'm going to be talking about the community-based form of palliative care delivery in Kerala. The community-based form is known for its low-cost, resource-effective framework of provision of care for terminally and chronically ill patients. I think to understand the model, we need to situate it against the global backdrop where we have the dominant forms of provision of care are broadly the hospices and the hospitals, which are primarily driven by medical professionals and are institution centric. So we have teams of medical professionals, including physicians, nurses, counselors, social workers who work around a patient and family. Now, despite over 60 years of the palliative care movement, you'll find that people refer to a global pandemic of untreated pain. So, and with more than 80% of the world's population not receiving effective palliative care, the challenges of a medical professional-driven approach becomes even more dramatic in the context of a developing country context, where you have your primary barriers to effective care will be really in terms of access and affordability. So indeed in India, you have less than 3% of our patients get access to effective palliative care. It's in this context, I guess, that the Kerala model gains salience. You have to understand this global backdrop and the Indian context in order to understand why the Kerala model becomes effective. It's also important to note that there was a high incidence of cancer during the 1980s and 1990s, where we have the international average was around 38%. Kerala would have been around 52%. And so there was an imperative to address the question of cancer-related pain, but very little awareness about palliative care, very little awareness about alternative methods of alternative models of how we could address such a large-scale issue. The Kerala model, as we've been talking about, has three key elements. The way I see it, the first is total care, where patients and families receive not just medical support but also financial, social, psychological, emotional support, bereavement and rehabilitation related support from community organizations. And so it's essentially a total care model for patients and families. The second is the idea of community being the locus of fundraising, caregiving, and decision making. So it's not something where a doctor comes in and says that this is how community volunteers should organize around what I'm going to do. But in fact, community volunteers can turn around and say, this is what we have, and they can hire a physician and a nurse to support their activities within a local region. And the third is, of course, it's the model's integration into the public health system. So I'm going to unpack these three elements. So when we're talking about total care, it came up in a context where community volunteers were interacting with the patients on an ongoing basis, and they found that, well, patients, what they termed as patient suffering was, in their own terms, just 20% of it was medical and 80% of it was really social. To give you an example, there was a team in northern Kerala that was on a home care visit to a patient's house and to a cancer patient's house. And a neighbor came along and said that my 20-year-old son, is bedridden and he fell from a coconut tree and splintered his back. So he's bedridden now, and he wishes that he had cancer, so some of you would come and visit. And so this got the volunteers thinking. They said, well, what's the difference in the suffering of a cancer patient and a bedridden, 20-year-old bedridden patient? Why can't we go there? And so this became a point of discussion, and eventually they decided to take up bedridden patients as well. As today, many people in the field would articulate, doctors would doctors understand symptoms while volunteers understood suffering. So it's on this basis that you see an emergence of total care. So it's not just the medical aspect, but the fact that my roof may be leaking or my child may be dropping out of school. So it's these issues around which the community mobilizes and provides total support for the family. The second question is around community as the basis of caregiving, fundraising, and decision making. So, well and truly, the previous example it said would illustrate that you have the community stepping in and taking decisions which physicians may not necessarily always agree on. So, if a physician could turn around and say that, well, we only address cancer patients, but because of the community's involvement, the model today in Kerala encompasses patient categories spanning chronic renal conditions, respiratory conditions, cardiovascular conditions, but also unconventional to the palliative care field. What we see is mental health conditions, geriatric patients, which would otherwise be considered within medical specializations, different specialities, but they get considered as palliative care patients within the Kerala community-based model because community volunteers recognize that that's what's important for their local community. The third aspect of it, which is integration into the public health system, is a more recent phenomenon. While the community form of functioning has been around since the early 1990s, the integration into the public health system is more recent. This was in 2008, where in response to bottom-up lobbying by community organizations, you find that the Kerala state government came out with a landmark policy in 2008 stating that all primary health centers needed to be trained um, in palliative care. So all nurses and doctors needed to receive palliative care training and would have basic equipment and medicines such as morphine available at the local level. This was significant because where community organizations in remote areas, for instance, might struggle with access to a doctor or a nurse or with access to medicines, here you had the government infrastructure committing to a certain degree of care. And indeed, today, government is the biggest provider of healthcare in terms of number of organizations as well as in terms of expenditure. So, while the mandate is that community organizations and government bodies can function in collaboration, that is still work in progress. It's something that needs to be realized in practice. And although there are certain communities which have managed to make that kind of dyad work well. So that's about the community model, and of course, it opens up so many questions because despite all these years of functioning, why hasn't the Kerala model built beyond the boundaries of Kerala as much? There have been independent efforts to translate the Kerala model to other geographies in India as well as outside India. So there are attempts to translate this to Bangladesh, to Sri Lanka, to Indonesia. Within India, there are attempts to translate this to Manipur, to Pondicherry, and West Bengal. And these have remained standalone efforts, of course, within their local contexts, very vibrant. But why hasn't it gained the same kind of traction that the Kerala model has within the boundaries of the state? So these may be specific to certain kinds of districts or cities, which makes us think about the context in Kerala. Is there something about Kerala's social and political context that enables this kind of community form? If so, what is it? What are the kind of historical political conditions that enable these kind of forms? Uh, it also begs the question that what does it take to translate a model like this to other geographies? So what really is it that makes a model like this tick? I'm going to leave you with those kind of questions to think about.
We're here with Dr. Ken Donaldson, Medical Director for the NHS, Dumfries and Galloway in Scotland. Ken has been kind enough to share some of his experiences of being a medical director that includes an acute care hospital in Dumfries. Ken, why do you think hospitals are equated with a bad death?
Going back maybe 20, 30 years, to come into hospital and spend a week, 2 weeks was fairly normal. these days, the wish is to have just a matter of days and then either back home or out to a setting in the community. But our demography has changed, and patients have multiple comorbidities. They may have heart failure, kidney failure, other organ failures, and when they present, they're complex. But the way the hospital is set to work, we're still looking for a diagnosis, something we can treat, something we can make people better. But often that's really not possible. But these patients then end up staying in the hospital for a period of time, perhaps having many tests and different treatments, when actually they are reaching the end of their life.
How has this continued to change in the last decade or so?
We have an ageing population of people who have multiple comorbidities, and that makes their presentation in an acute hospital more complex than it was, say, 15, 20 years ago. I can remember myself when I was doing medical receiving, the patients who came in when I was a junior doctor had a heart attack or a stroke or an exacerbation of their COPD. And I think this has changed over the last 15 years for many factors. There's a lot of good secondary prevention. There's preventing, preventing death at an earlier age. So people are living longer, but they carry this burden of comorbidity. Along with the change in demography, we've seen a change in our workforce, and we are struggling to, well, for a while, and still is, doctors, but also nurses and AHPs and pharmacists. So there's a difficulty in recruiting all these healthcare professionals, and that puts an extra strain on our staff in that they perhaps don't have the time to really get into some of the detail of patients. And with numbers increasing through the front door, that can lead to just trying to process patients quite quickly to get to the problem, move them on, and we're not really dealing with the actual heart of the matter, which might be somebody who's reaching the end of their life.
I'm wondering if you can speak a bit about what specific characteristics might make a death bad or good from the patient and family member perspective in the hospital.
Often I've seen many families in particular when I'm speaking to them in the bereavement phase, and the anger is that we didn't know mum or dad was dying until the day before when they told us that he died. But we look back and we realise she'd been dying for weeks, but we didn't have time to say our goodbye and process that. And I think that's that important, that palliative approach, which you can still be doing the old test and be thinking about treatment, but if you're thinking, well, perhaps the patient is reaching the end of their life, you can have that honest conversation with both patient and family, and that can relieve that trauma.
Clinicians can have a hard time because individualizing care can be challenging. So I'm curious from your perspective for you to talk about some of those differences and how clinicians and the system negotiate that.
Everybody has a different take on what they perhaps see their own death being like, and I think that can often change through time as well. That people may say, "Oh, this is I want to die at home and I want this," and then but actually as it comes nearer and they perhaps there's a bit of fear about being at home, then it may change. The important thing for our clinical colleagues is that recognising that individualism and treating every patient as that single person, what it is what matters to them. And the difficult bit, and I feel this myself, having done it for many years, is getting beyond what I think is the right thing, and it's what they believe is the right thing, and ensuring that we share a bit of each other, so that I know what it is matters to them, and they perhaps understand what my specialist experience in this area is, so we can do the right thing for each individual patient and their loved ones.